Hey, everybody, and welcome to the Migraine Mentors minicast with your hosts, Dr. Eric Reese and Dr. Thompson Mayasaka. And we are excited to have you here today because we're talking about a unique topic that is relevant to migraine and migraine symptoms. We're going to talk about vestibular migraine. And for those of you out there who've dealt with it, it's not fun and it's not enjoyable. For those of you who've heard about it, I'm sure you can resonate and relate to the same thing. But we want to kind of take a different take and approach on vestibular migraine and talk to you a bit more about the whole migraine family as a whole. And Thompson, one of the first questions I kind of want to ask you and really get your take on is just talking generally about migraine. I know there's been this back and forth about is migraine, is it neurological, is it vascular, or is it both? Like, what does the data and research currently show us today?
Yeah, most people will be a little surprised to know there's been this back and forth argument in the scientific community for hundreds and hundreds of years over whether it's a blood vessel disease or a neurologic disease. So ultimately, there's issues with both, right? It's kind of what's the main contributor. So many years ago, the first theory was vascular, and then this English philosopher came along and said, well, it's actually more like a nerve storm that behaves like a seizure. And then a bunch of research went into medications, and we decided it was a vascular phenomenon. It just goes back and forth. And I think that, especially since the 90s, the sort of resurgence of the neurologic model, is what it's called, has led to a lot of really interesting, not only therapies, but interesting research that help us clearly define migraine. And Eric, what we were talking about earlier, I think gives a really easy way to understand migraine and really demystify it, make it less complex. Because when you look at it, like Eric is about to explain, it just makes it easier. And I think if you understand what you're going through, it makes it less terrifying. Eric, what was you were talking before about what you said to a patient, and I thought it was the perfect way to describe it. Could you summarize that for the people listening?
So I was talking with a patient earlier about just different aspects of migraine and what's actually going on with migraine itself. And I was saying, listen, there's so many different subtypes and types of migraine, but I look at migraine as like the the axle on the wheel, right? And then you have all these different categories or aspects of the migraine itself, right? So you have a vestibular migraine, which involves the vestibular system. You have migraine with or without aura, which is pretty self-explanatory. You have ocular migraine, which involves the eyes in some way. You have all of these different types of migraine themselves, but at the end of the day, they're all sharing some sort of similarity. And the fact that they all do involve neurological and then vascular changes. But what I was saying is that they're not really that different from a treatment and a therapeutic perspective. And the reason why I'm saying that, and it might be a bit controversial, is the fact that let's take five different cars that are so the same car, but they have different problems, but they all get in the same crash. So everyone's driving a 2022 Chevy Cruze, right? But the first car that runs into the guardrail has a really bad axle. So the car is going to get damaged in a specific way because that axle is weaker. Let's say the next car was, had a defect in the front right fender. And all of a sudden the car gets in the exact same accident, but it has different damage manifesting based off of that. The third car was going slower or going faster, right? But it was the exact same car as the previous ones. They all have these outcomes that are different, but at the end of the day, it's still the same event. And that's really kind of not only clinically what we've seen with the approaches we take, but what we've seen with patients. And that's why we're so focused on being specific on personalization and individuality. And Hamza, I know you have a lot to add to that conversation as well, because it's so frustrating when patients come in being like, I have this, but everyone's treated me like a cookie cut approach and no one can figure me out.
Yeah, totally. That I love that example. The example that I use with patients. Well, before we go there, there's really one fairly recent discovery in terms of migraine that helps understand this more. And that is, in general, when you look at something called electrolytes, things like sodium, potassium, magnesium, those things help maintain a good, healthy neuron. And one characteristic of a healthy neuron is something called a large membrane potential. All that means is just there's a big difference in charge from outside to in. So it takes a big, healthy punch to that neuron to say, hey, we need you to turn on and do your thing. And so one of the characteristics of migraine that has a lot to do with the genetics of it, is the cells will leak out electrolytes accidentally. So what that does is it takes that big healthy membrane potential, a big difference from inside to outside, and it makes it small and much more likely for that neuron to either discharge spontaneously or just fail with repeated stimulation. That's why there's a whole channel of drugs called calcium channel blockers, is to prevent that from happening. So if you know that people with migraine have this sort of leaky cellular nature, it makes them very susceptible to fatigue. And then when migraine happens, which if you look at it under an imaging modality, it kind of looks like a little seizure. It starts in the back of your brain, which processes vision, which is why a lot of people have a visual aura. It just kind of slowly and methodically works its way throughout the entire brain. And so any area that was especially leaky during that event will fatigue and give you symptoms. So the analogy I use with patients a lot is, it's like if you guys remember during COVID and you lived in a small town with a lot of small businesses, a lot of the small businesses that were just kind of struggling and barely hanging on when COVID hit are going to fail. They're going to go under because they just didn't have enough spare cash. Whereas, the McDonald's and the Walgreens and the, big grocery store chains will be fine because they have, they're healthy. So if you look at migraine through that lens, if you look at what areas are failing and giving you symptoms, the mechanism of migraine symptoms is all relatively the same, Eric, to your point. It's just different areas in the system fail, and those different areas have different functions.
That's where a lot of people do get confused. I think that there's a lot of docs that get confused too. And I'm not saying that we have the exact plan or makeup for it, but clinically, what I've seen and what I've seen in the data and the research is that there's a failure in a specific area of the brain, right? So if you take a look at the brain as like a real estate map, you're looking at like neighborhoods or boroughs. And maybe one neighborhood's weaker or stronger than the other. Well, that gives you a different manifestation of symptoms. And it's our job as docs to not only understand that, but as a patient, it kind of makes more sense as to why you would kind of have this manifestation of these symptoms. And so I love that analogy. And, I guess what we're trying to say in a nutshell is that if you've been labeled with a specific type of migraine, you might need specific types of treatments. But if I have 20 patients who have a vestibular migraine in front of me, every single one of them is going to need a different treatment plan. I think a lot of patients assume that we just have standardized treatment plans. And while there's protocols, you're always trying to figure out the next best step to help that person. Every person is different. Every patient is different. Every brain is different. And that's beautiful. But you have to respect that. So, with that being said, Thompson, for those people out there who are struggling with vestibular migraine, everyone's going to ask the question, okay, listen, I don't want the homework. I want the answers. Like, what do they look for? What do they do? What should they expect with a doctor or their next therapy treatment? Like, what should they kind of look for to know that they're getting the appropriate care to actually help with these vestibular based migraine?
That's a great question, and I run into these problems quite frequently. Is people will get the diagnosis of vestibular migraine, and they'll go right to some sort of big box vestibular rehab
Mm-hmm.
program. And the important thing to understand about vestibular issues is they come in two classes, two flavors. One is called peripheral, in which case most PTs and traditional types of therapies do quite well. And then there's central vertigo and central dizziness, which requires an entirely different strategy. So I think it's really important to know the difference. So if you have what's called BPPV, or if you sneezed and sort of plugged it and you create what's called a fistula, or you have Meniere's disease, there are all these issues with the actual vestibular organ in which a certain type of therapy is going to be effective. Essentially, you just stimulate it over and over until it works again. It's called habituation therapy. And that is effective if it's a peripheral issue. The difference is a central issue is when one or more systems disagree with each other. So your eyes don't say the same thing as your neck, or it's called visually induced vertigo, or if you've heard of cervicogenic vertigo, that just means vertigo that comes from your neck. So central vertigo is usually a combination of either neck-related issues, eye-related issues, or a combination of the three of them, with vestibular being the third. That often requires a little bit more nuanced type of approach, and sometimes just has to deal with a system that's not your vestibular system at all. So I would be very careful about pursuing either direction. Be sure to ask your clinician, is this peripheral issue or a central issue? And if they can't answer it, I would maybe give a second thought. It's just really important to figure out what the issue is so you're actually treating the correct issue. Eric, I know you've run into a ton of issues with that.
Yeah, once you get through that first phase, I think it's kind of game on, right? So if it's a peripheral vestibular issue, you go after it, you treat it, you rehab it. If it's a central issue, unfortunately, you kind of approach it with a little bit more of a thought process because visual issues can cause vestibular problems. Neck problems can cause visual issues. If you don't believe me, take your fingers, put them on the back of your skull back here where everyone feels tension headaches, and kick your eyes left and right and up and down. And you're going to feel all of those suboccipital muscles back there contract and relax based off of the fact you moved your eyes. I mean, you see it just as commonly as I do, Thompson. Patients come in, they've seen a bunch of docs, they've had all the soft tissue therapies, everything done to their neck. And the problem is they still have neck pain or they still have some sort of syndrome back here. And no one's looked at the eyes. No one's looked at the vestibular system. And so those are the three friends that have to go to the same party and tell you the same story. So as much as I'd love to say, hey, here's exactly what you need, here's where to go, hopefully what we've given you is the thought process behind what you should be asking as a patient or as a provider. And now you can start taking the scientific approach to say, here's what I think is going to happen. Let's try it. If it works, great, on to the next one. But if not, then you challenge that thinking and try something new. So one thing that I will say to people listening here is Thompson and I were having a conversation earlier yesterday just talking about just basic things that we kind of take for granted. And for a while, I had just written off like electrolytes as like, are they really that therapeutic? Like, do they really matter? Like, you get them through food, and you put sodium, use sodium and chloride on your food. Like, you put salt on your food. Of course, you're going to get them in, but like, are you getting enough in? Are you getting the right dose? Do you have enough chloride? And a lot of people are magnesium deficient. So I was just kind of just reminiscing a bit about how it's so good to have these conversations and challenge your thinking. And I appreciate that because when you think about electrolytes, you're like, oh, they're so basic and simple, but they can be so effective. And we've both seen that clinically. So, yeah. Thompson, anything that you want to leave everybody listening with as far as maybe it's like a parting kind of message?
Yeah, I mean, if you're out there and you're struggling, I would be really optimistic about some of the therapies that are going to come out over the next 10, 15 years, even the next 5, just because our understanding of brain things is developing so quickly. The understanding of the neurologic causes of migraine is also expanding quickly, which means that there are people much smarter than Dr. Reese and I coming up with therapies and treatments that are validated by the scientific method. So a lot of really exciting stuff is going to come out in the next relatively quick period of time. So just be optimistic. There's never been a better time in the migraine world than right now, just because of all the stuff that's happening in that space. So just keep trying, keep your head up, don't give up. You only lose this game if you give up and stop seeking answers. And we'll do our best to keep you up to date on the cool stuff that's happening.
Love that. And isn't that the truth? That's a great way to send people off. So for those of you who want to kind of reach out, contact us. Once again, Dr. Reese and Dr. Miyasaka, we are the migraine mentors. We practice out of the Neural Connection in Edina, Minnesota as well. So we're here to support, guide, educate, and hopefully empower people struggling with migraine symptoms to overcome their issues and get better. So that's it for this Migraine Mentors minicast, and we'll see you at the next episode.